We're live. We're back.
We're back.
So we were gone last week because I was traveling over the Atlantic and like a lot of stuff happened. Oh no, we did our 15-minute live from the Sky Club.
Yeah, I didn't even know you guys were going live. All of a sudden, I just
We
saw it.
didn't know either,
What is
Melissa.
going on? I
We
was
didn't
like,
I just
know.
set it up, and she was walking through the airport. It was a
oh,
whole
she was
chaotic
actually
situation.
boarding. She was boarding the plane.
She was boarding.
Yeah,
Yeah.
it was that was like some high-end situation there. Well, anyways, so we have a big news show because we missed last week for real news. And then we have like an actual very legitimate guest, Dr. Dev Sangvai, who is like the Secretary of Health for North Carolina. Y'all, what?
We're gonna be
So
two for
he's-
two. Like we're gonna be. What's amazing for us in North Carolina, just the most
God bless
incredible
North
leaders
Carolina.
who agree to come on our ridiculous show. So that's
I don't
also
know.
amazing.
It was great
We're very
though.
excited.
Thank you so
Very
much,
excited.
Heather. I appreciate
Well, all
it.
of America does watch it, so I feel like this was the right move from your comms team. High five.
That's
But we are going to put him backstage so that while we're doing our news commentary, he can decide to leave us.
It's gonna be
So,
great.
Deb, we're sending you back. We'll bring you back in a little bit. So we got big news. Melissa, we'll send you away too, just to preserve your own
Spare you.
reputation. So we got some big news, y'all. So here's the deck Lisa hasn't seen yet. So we're just gonna improv our way through it because we have real jobs, except Lisa's soon to have a different real job, which we'll go into in a minute. As you can see, her title is Lisa Berry, free agent. Yeah. So we're going to start out by Lisa's been sending me a lot of this guy, Joe Lonsdale's tweets lately. So I was like, I don't even know who this guy is. I looked him up. He's the Palantir guy.
How do you not know who Joe Lonsdale is, Kat?
Listen,
If you're
Lisa,
gonna,
I
if
know
people are
information that
going
you
to
sent
believe
me.
that you are really a lady Republican, you need to know who Joe Lonsdale is. Come on.
Well, now I do. Anyway, this guy actually has like pretty great tweets. But
Yep.
I do think what he's saying here is important all around. Whoever tells you to stop thinking for yourself, asking questions, to shut up and go along, they're the bad guys, left or right. So, America, please use your brains, especially as you listen to us.
This is also because like Joe was making some like very reasonable and thoughtful points about free trade. We're not going to get into that here today, but y'all, like, this is a big deal. And of course, he was getting brigaded and like attacked on Twitter or X, whatever we call it these days. And so, like, this is a reasonable commentary, though. If anyone tells you to stop thinking, then you should walk away quickly.
Yeah, that sounds dumb, and I do think that goes for all parties. Although
that's correct.
I was having a debate with someone via it wasn't a debate; it was more like high five. We were just high fiving each other, all the time on the text message because I've been doing this like all these. Well, I've done exactly 2 posts about public health as a lady right of center person.
That's
about
right.
like, hey, public health is like reasonable and like, I don't know. I actually do believe most people are moderates. Like I genuinely believe that. And people are scared to talk about what they think. And that's cool. You know what? I'm not. So Lisa's not. Especially now, because as you can see, she is a free agent, which brings us to our slide about Lisa Berry getting a new job. Look at Also, this is a great photo. This is like, you know what this photo looks like, Lisa? This photo looks like the next national coordinator.
Yeah. It looks like somebody who has, unfortunately for everyone else, no shame about standing up in front of hundreds and hundreds of people and saying some stuff. So sorry, I just was missing that like gene to have any kind of shame about public speaking, and I don't even get butterflies anymore, which is the really upsetting part for me and for everyone. But yeah, I announced a couple days ago that I'll be leaving Civitas as the founding CEO of Civitas for the last 3.5 years. Before that, was the interim CEO of one of the predecessor organizations. And then today, like super exciting, probably coming up, we announced the next CEO. But I'm a free agent. I was informed that I am no longer the CEO of Civitas as of today because we have hired a new amazing person. So
who is
Jolie Rizzo, who has been the VP of Strategy and Network Engagement at Civitas. She is amazing. She is just an incredible leader, super dedicated to the organization. Members already know her and love her. And the board made the right decision, in my opinion, to appoint Jolie the interim CEO, and super excited for what she's going to do with Civitas. So I'm on garden leave. I literally was digging up stuff in the garden yesterday, just trying to be useful, but also trying to finally weed my dirty patch of weeds outside my house. So
Well,
very
that's awesome.
exciting. Very exciting.
Good transition. Julie's a great choice. I hope she becomes permanent CEO of Civitas. I think she does a great
Same.
job advocating, herding cats, all the things. So
Yeah.
super smart, and congratulations, Lisa. So any tips on where you might be going other than some of the ones that I may have Easter egged in my recent LinkedIn posts?
Yeah. Yeah. Well, people, inquiring minds really want to know. I mean, I get all kinds of text messages and phone calls and LinkedIn messages, which is very good for my ego. So thank you, everyone. I love you all too. I, have not yet announced, for a variety of legal reasons, what my next move will be, but the world will know soon. I've heard people say all kinds of interesting ideas and throwing things around, and rumors are spreading, but it's a job. I'll have a job. I think. I hope. I hope.
Well, you can always come work at Incenna. It doesn't
That's
work.
right. That's
It
right.
doesn't
That's
come on
right.
over. You're already on our Slack
That's right.
channel, so it all works out.
Right.
So
That's right.
anyway,
So I'm either going to Incenna or I'm going to somewhere else, or I'm doing another big thing, and we'll all know soon. And hopefully, again, I actually have a job as of next month, but TBD on that one. And
so exciting.
Legal reasons.
So exciting.
Conflicts.
Oh my god. Oh my God. Inquiring minds want to know. Look at all this drama. Oh my gosh. I mean, Susan, maybe it was all just a big ploy that we spread the rumor that I was the national coordinator and it was actually Lisa. I don't know. Anyway,
right.
Okay.
That's right.
Well, we'll see. Keep.
I'll just say one thing, just very cheesy, heartfelt moment here for me is I have had this most incredible opportunity in my career to found and lead Civitas over the last 3.5 years. And I have an amazing team and there's great members who've done incredible work. And just, it's been this huge opportunity for me. And I've worked a lot. I've worked 24/7, 365, it feels like, for the last X number of years. But I do it because I absolutely love it. And it's been so wonderful. And I'm super, super happy. It's not often you get this chance to, to maybe make a little bit of space when you move, right? It's not bad to leave a job, because when you move, other things can move for other people. And I'm just so happy that Jolie is taking on the role. And it just feels like this really wonderful moment where we worked together for so long. And now me moving out of the way means a big opportunity for her and probably new things for the organization. So dear loyal fans of the talk show, it's okay to leave jobs and do different things, and it's it's great. You have relationships for life, and then you bring them into your next role, and it's really wonderful. And so I'm just super proud, super excited, scared a little bit for me and what's happening next. It's a big job for me. It's a big change. Lots of stuff is changing, but it's cool. That's part of life and careers these days, right?
That's what I'm fucking talking about.
Sappy part over.
We'll see. Maybe we'll announce where you're going on the talk show next time, but it sounds like maybe not today. But who knows? We never know what's going to happen. So congratulations again, Jolie, new CEO of Civitas. So starting out, looks like the rate increases for Medicare Advantage were published, an increase of 310 basis points, which no one expected. WTF.
The death of MA was apparently premature.
Exactly.
MA is back. We're back, baby.
Yeah, MA is back, y'all. What? And I think that there was, what was the drama? Part of it is we all read the news and we make shit up all the time. But Dr. Ross was a pretty big proponent of Medicare Advantage, and there was some stuff of him saying that it's there's too much Medicare Advantage. He said something like that, and everybody was Medicare Advantage is dead. Blah, blah. And then this came out. What the hell? This is actually a screenshot taken from Farzad's post on the X. With real math. And he had some other interesting observations, right? One is that this is actually just everything, this wasn't policy, this wasn't politicking, this was just actually, I guess, what they're required to do in law and math. Yeah. Which is interesting and exciting. And honestly, I think kind of a bright spot. Math is cool. Most of the time. Yeah. He has a really interesting tweet thread that, of course, Lisa shared with me, which is how I know about it. And this I took from it because I thought it was interesting that a lot of the drama and money issues were related to adding supplemental benefits and trying to win beneficiaries that way. So I like that he said this, that like, hey, I hope this doesn't happen. Like, I hope people are responsible. I hope so too, because I do think, despite the fact that they're all going to get a little bit more money, I do think that there are changes coming that will drastically impact Medicare Advantage plans. So that's my opinion. I don't know, Lisa, what do you think?
Well, I mean, I actually, one thing I forgot to send you, which we can put in the notes. I was listening to the At the Crossing podcast. It's from Rubicon founders, who, if you don't know, are very influential in the new administration. A lot of people from Rubicon are part of CMMI and CMS and HHS, and their team had a really great episode on ACO REACH and next steps there. And they were talking about how there are changes that need to come to ACO REACH because it's also based on these overall Medicare benchmarks, which are also influenced by these changes around MA. So like all this stuff is connected, and there are going to be some really important and very policy nerdy updates that CMS and CMMI have to make really quickly around things like MA, MSSP, ACO REACH, others. So these are all connected. This thing right here that Farzad notes, this is something that we've heard about MA for a while, which is that obviously, like these MA plans, they compete to get the healthiest and the youngest Medicare beneficiaries with things like gym memberships and like supplemental stuff that like whatever. And there's a ton of it. The problem is it's like never been evaluated to understand like, why is it okay for the government to pay for that for some people, but not other people through these supplemental benefits? So like, why don't we just offer like whatever those are to all Medicare beneficiaries? Why is it coming through this one particular thing to allow MA plans to pick off the healthiest and the youngest people with certain characteristics? Like, then that totally changes the calculus about, whether a plan makes sense for both the beneficiaries and also for the government and for the taxpayers. So just lots of issues here. Like, would love to see how this plays out as well, Farzad.
TBD. Maybe we should ask them to be on the show. So
yeah,
we should do that. Speaking of social media platforms, which we hang out on a lot. CMS has an Instagram. Lisa just sent it to me. They have an Instagram. Lisa and I are one of like their first 100 followers. So like, get on that, America. We are interested in all the messages being where people are, which is on our Instagram reels. So
that's right.
I don't know.
That's right.
I wonder if they'll do a TikTok. Probably not. But maybe. Who knows? Okay, so speaking of MA, Stat has done this like exceptional series about how, according to the reporting, corrupt United Healthcare is, and they've gone through like a whole bunch of stuff. They kind of like stopped the reporting for like a minute when Brian Thompson was murdered, which I thought was well done. But they actually just won some awards for their coverage of United Healthcare, and including other stories, and so. This is all about continuing their story about upcoding, RAF tactics and things like that. And we have heard through probably mostly reliable sources that, again, with Medicare Advantage, big changes are coming to avoid some of these nasty poo tactics. So I do think getting that increase is awesome for Medicare Advantage. Again, I do think that stories like this do matter. And the government's still trying to save a shit ton of money. So that money is coming from somewhere that they'll be saving. It's probably going to be more restrictive guardrails around what can be done with Medicare Advantage, or so is my guess.
Yeah, I mean, again, United is a massive, massive company. And they have this huge, huge, huge part of this market. And, this is how you see the sort of like the coding, the algorithmic, the technology, the analytical, like arms race between, a payer who is incentivized to do this and like the rest of the system and providers and you name it. And like, everybody needs these guardrails to keep us focused on like delivering appropriate care. That's what it is. We need them.
Boom. Yeah, I think it's going to happen. Also, Scott Stewie, listen, Lisa and I will totally come to your conference if you invite us and let us have a debate with each other. Absolutely. I'll be there. No problem. Call us. Okay, so like, I don't know, we missed the talk show the week that the government laid off like a bajillion people. But I feel like there's been a lot of coverage of that. So you probably know how we feel about it. But also this week, there was some questionable stuff, right? Some judges said like, hey, you got to rehire all these people that you fired, the probationary people, not even counting the RIF people. from last week. And then, we got this news alert like, oh, hey, never mind. They're not coming back. We also saw there was also the thing about RFK saying, no, 20% of the RIF was a mistake. We'll bring them back. But then there's some Politico coverage, which is, I'm like really into Politico these days. Like they got all the deets. They said like, actually, there's no plans to bring anyone back.
There's no plans. Yeah. Yeah, listen, I mean, this just sucks for people, right? These people, they probably want to move on at this point. It was really, really devastating for a lot of federal workers who had, dedicated their careers to this work and just were like, totally shocked at these actions. And like, I think they probably want to move on, like pay them their severance, like do the right things, for these people, like make sure that they are covered with like what they are legally entitled to and be kind to them and like let them go and do the rest of their lives. Like this back and forth is not helpful.
Yeah. It's not great. It's like hard enough. Like these people,
Yeah.
I wish there was some sort of support on like reskilling, maybe not upskilling, because I think that's kind of douchey and demeaning, like reskilling these people, because honestly, America, like how many policy analysts can we absorb in a short amount of time? Like probably not that many. So this is like, I don't know. I like, again, I'm like pro efficiency.
The Partnership for Public Service I had a really great post. We can link to it in the show, like the after the show posts, with like a bunch of resources for federal workers who are moving to different careers. And like, they're really great. Partnership Public Service, really wonderful. And so there are some resources out there. There are organizations who care about this, but like, again, it's like, people need to move on and do the next thing in their lives now. Like they're not going to sit around, rightfully.
Yeah. As I noted in one of my Ranty Lincoln posts today, the CDC Injury Center, the team working on opioid overdoses was not riffed, which I appreciate.
Good.
I appreciate that. We're just going to focus on the positives. So yeah. Also I know there's been a lot of controversy about this. I would just like to say objectively, if RFK identifies as the causes of autism by September, that is fucking great.
Sure. I mean, I gotta get. Do you want to bet on it? I think I know the answer.
Making any bets with you?
It's almost certainly the like 7 like bottle caps of microplastics in all of our brains. Just saying.
Yeah, I think it's fluoride.
Autism is a complex disease state made up of many different factors, genetic, environmental, you name it. We are just way better at identifying it now. That's my real bet. I was making a joke about the microplastics in brains, but then I realized that like this is actually very serious for a lot of people. And I'm saying like we are just a lot better at identifying and naming this as autism.
Yeah, I think I appreciate the focus. I think this makes a lot of people.
Let's do some research.
Agree. I think again, like I've been ranting about this a lot. I think one of the big problems we have as like health people in the government, not I'm not in the government, whatever you were once, whatever. Maybe again, we don't know. It's like the communication about what the government is doing and the research they are funding to private organizations is like so poorly communicated to the general public. Yeah. Like there are tons of people working on this problem. Like there are. Yeah. It's just that like it's like here, there, and everywhere. You get bits and pieces of information, and there's no comprehensive communications approach to, hey, this is what the hell we're doing for autism. People don't know. Like they hear one little thing, they're like, whatever. So like again, like not to keep shitting on the comms teams of the great federal government, but Jesus Christ, y'all, you could have done better. Start now. When's the best time to plant a tree? What?
Well, 20 years ago, the second best time is now. And I just like exactly like, and nobody wanted to pay for this kind of stuff, pay for the comms part. Comms is important. It helps people understand what you're doing, why it matters, like why it's relevant, know what's going to happen next. They have to invest in this communication part. No secretive communication, no crappy 100-page PDFs. Like let's communicate.
No, like formal bullshit, because you can't, like, I don't know, the way the way they communicate and the way they interpret communications changes. We need to meet people where they're at, non-traditional platforms, non-traditional approaches to like even writing. Like this summary here, this is like a Grok summary or something. Like even the way AI does this is better than the CDC and other health communicators from the government have communicated. Like it's short, it's concise. I'm like, okay. It's not 4,000 words. Anyway, whatever.
I agree.
But anyway, I will say, like, I think if this happens, that is a great thing for America and humanity. I hope that it happens.
Cool. Fingers crossed.
Also, this is like non-industry news, y'all, but anyone who's interested in going to consulting for the government, I would recommend against that.
Right.
Yeah.
Which is the other
Yeah.
problem, right? Which is the other problem with federal employees losing their jobs en masse. A lot of federal employees worked for government consulting firms because their skills were directly transferable because of the way the government has set up sort of all of its staffing, which is to outsource a huge amount to consulting firms versus employed people. I would personally like there to be more federal employees and maybe a little bit less outsourcing, some kind of better balance there. But that's not the way we've gone. And so when massive contracts get cut to consulting firms and we lay off a bunch of federal employees, that is a double crisis, as well as that really amplifies the numbers. It's not 10,000 or 20,000, it's way more people. This is an example.
Yeah. Is there any actual, like, do we have an estimate from the consulting world about how many jobs they've lost related to government?
I haven't seen one, but like that will be a very interesting part of the story to understand. I mean, some people can be moved around, I'm sure, but I'm sure a bunch of people just lost their jobs. And there's not really a ton of communication about that.
There's a person I follow on LinkedIn, Chris something. I can't. It's a Chris female with a K. She has been posting like pretty good coverage of like all of the contracts that she's discovered and how much they're being cut. Now, money doesn't directly equate to people. It does, but not like it's not like a 1-to-1. So it's a lot. I mean, it's a lot. So I can only imagine that the employment crisis with consulting firms is not small. Lisa, if you had, so like, let's like not debate whether or not the government should have been downsized 20%. Like, let's just debate how we would do it if we had to. Like, how would you do it?
How I would downsize the government? I would certainly look at federal contracts and I would renegotiate many of them. I really like the idea that we were messaging about earlier, which is that, so many contracts are just like these like really thin margins. So you need this massive scale. And then they're also super, super restrictive. Everyone knows it's really hard to compete for government contracts. You need a PhD in government contracting to compete for government contracts. And so making that process dramatically simpler and really as much as possible being outcomes based would probably very much result in better outcomes for the government. To be clear, like, a variety of people and organizations have been trying to improve that for many years, but that's been a real weakness. Also, we've talked about Jen Palka and her book about the like doing technology in government and like that process there, and part of the digital service and all these things. And she really made the critically important point that a huge amount of the federal workforce she was on the Freakonomics podcast recently, sort of talking about this again. Huge part of the federal workforce is like project and program managers, but not product managers who are building and delivering products and doing service delivery, because the government has for so long tried to outsource every piece of that. But not having product managers and people actually building products and delivering services to people inside the government brings this sort of weakness and this dependence on outsourcing that is just honestly very poor for actual outcomes. So maybe it's moving some of those core product functions inside of government again and still doing outsourcing to support like advanced technology and whatever else. But like having people in the government who can do that product and service delivery improvement level work will probably result in better outcomes for Americans. And so, I mean, obviously Jen Palka is brilliant, and they would be foolish to not listen to her, but this is an idea that, could use some focus. I would do that, I think.
Yeah.
Bring the product and the delivery inside.
Yeah. I mean, I think part of this might be awful, but like, hello, you've watched our show for a while. You know that I'm the awful one. But I would do a few things. I would, what's the
I
law
have no
where you
state,
can't fire?
but thank you.
Listen, I would work with Congress. I know.
That's right.
And I would like change the law or whatever that says you can't fire government employees for no reason. Or for like, you should be able to fire anyone at will. Like, God bless America. And as a small business owner, I will tell you, I am pro firing people for no reason. But like it doesn't make sense that you have to go through an incredibly terrible process to let people go who are awful. And I'm not saying these people are awful, but I'm saying like there's a lot of reasons the government is so huge. Also, I would change this law so you can fire people. It's at will employment, whatever. And then
I hope you're
would
planning on
remove-
increasing salaries then, because that's the
my
trade-off.
next thing. I would remove the caps on whatever
That's
this
right,
GS
girl.
system, because here's the thing, like, this is the terrible part. If you can only hire people and the max they can make is what, a fucking $180,000, and that is the top of your goddamn career, I'm sorry, America, you're not hiring the best people. You're not. You're hiring people that just either they already have money or like they just freaking believe. Now, I'm sorry. I know we've said a lot like these people all believe. They all don't believe. They all don't believe. For a lot of them, this is like you're getting people where that is good enough for them. And the top performers in America are making a shit fuck ton more than that. So I would just compete for amazing people, right? And if it's at will employment, you're able to increase salaries. You're able to hire people who know what the hell they're doing, and you don't need 10 contractors for every federal employee. And we have like a high functioning like employment group at the government doing cool stuff. That's what I would do. I'm like also working with Congress. While I'm not great at collaborative, like consensus-based decision making, it's not my jam, as you know, Lisa, being on my board at Zoria Foundation, not my jam. Don't know how to run a board, but it would also give people time to know what's coming, because I do think that they need to reach.
This is
I just
true.
want to super rant there.
It's a good episode. Yeah.
Well, anyway, whatever.
I love that.
But also, like, I do think it's unfair that these people had they had notice, but like also everyone thought that this couldn't happen. In fact, judges are saying it shouldn't have happened. And I just think people needed more time, and we should have done this a more legitimate way. And we could have been like pro innovation, pro high performance. We're almost kind of stuck in the same position we were, with just less people and a lot of lawsuits.
Well, I don't agree with you, but I agree with some of it. I don't agree with the whole thing. I agree with some of it. I do think that public service needs to be elevated at some level, and not just in the same way as you would operate in any other business. But I think there are a lot of good things about what you said. I'm open to many of them. And maybe Jen Paco will come on our show someday, because she's amazing as well. So maybe she can talk to us more about her insights.
Yeah. And I do want to say there are federal employees who they just freaking believe, like they love federal service. Like, God bless them. That's amazing. That's not all of them.
Right.
Like, that's what I'm saying here. We can't paint everybody as bad. We can't paint them all as like angels from heaven. Right. Like,
that's right.
There are performance issues that should be addressed. And that's just how like employment should work. But well, I feel better now.
Great. Including with contractors, to be clear. There are some contractors who are fantastic, and there are some who are not so great. And so there you go. Like you need to like have the right like controls and structure in place to get good outcomes for the money that we pay, right? 5.1 billion. I mean, this is for, this is Pentagon, this is for defense, a little bit different, but still like, that's a lot of money to me, at least.
That is a lot of cash money, for sure. I don't know. Anyway, moving on. I just got that very pro-business right of center ran out. I feel better. Okay. Okay. You mentioned this thing that I thought was worth posting here. I couldn't copy and paste all 9 of Mark Cuban's points, Lisa, but they were good. And many of them like spoke to me.
They were really good. And once again, like Mark Cuban also should come on our show, and clearly has lots of things to say on Graham Walker's podcast. You can say it on our show as well. He is really awesome. He's also keynoting the 32BJ, which is a union, Cat. They have a conference this fall in New York, and he's actually going to be speaking at their healthcare conference, which is really cool. So just a shout out to them. They're awesome. And also Mark Cuban come on our show for the 50th time.
Well, I don't like unions, but Lisa, I'm supportive of all the things you love, mostly in general, in theory. All right. Hinge Health.
What?
Calling off its IPO due to drama llamas in the market. What?
That was bad timing, man. That was bad timing.
This makes sense to me.
This makes sense to me.
So,
sorry, guys. It's not going to happen right now. Like, you need to chill for a minute. I'm sorry. Yeah.
I don't know. Whoops. Okay, maybe later. I mean, you guys been waiting for years anyway. Like, just wait a little while longer. It's no problem.
Yeah.
Okay, so we're going to transition into our super special guest, who I don't think has signed up yet after our ranting there. So that's great. But So we have one actual scripted question for him, and then the rest that we don't know he's going to tell us, which is exciting. But there is some drama, as you all have probably seen on the internet, about a lot of states being super worried about bridging the gap between expiring Obamacare subsidies for the exchanges, which did add hundreds of thousands of insured people to the great United States of America, and them having massively increased premiums, and so people just dropping out because they can't afford it. So this little paragraph is from this Politico article. And it's specifically about Washington State. They estimate that they're going to lose 25% of enrollees due to cost increases, premium increases, if Obamacare subsidies are lost, expire and are not renewed or in some way rectified. They expect state premiums to jump 72%. So that's a lot. The other part of this, and we want to ask our guest, Dev, is that there are 9 states that actually have trigger laws that will roll back Medicaid expansion if the subsidies do not remain in effect. So that's pretty wild. And one of those is North Carolina. So Arizona, Arkansas, Illinois, Indiana, Montana, New Hampshire, North Carolina, Utah, and Virginia. And then there are a bunch of other states that can roll it back. I think there's like 20 or 30. So this is kind of risky, and we want to hear about what's going on in North Carolina and what they're thinking of doing. So, Liz, anything to say about that before we get our legitimate actual expert on here?
No, let's bring the expert on the show.
He's still
Secretary Sangvai, you're here.
Hi there.
So, Deb, please introduce yourself first, just so all of our hundreds of loyal fans, maybe thousands, millions, know who you are and why you're actually qualified to talk on this topic.
Well, that's great. Thank you for having me join the Health Tech Talk Show. Lisa and Kat, it's been great. And when that expert shows up, will you let me know? Because I'd like to hear from them too.
We'll let you know. Just keep going until they show
up. So I've been in the job of Secretary of Health and Human Services for a little over 12 weeks. And I come here with considerable experience in North Carolina. Been here for about 20 years, worked in the private sector, worked in academic medicine, spent some time working for a joint venture insurance company. So bring to the role a number of experiences that really converge on improving the health, safety, and wellness of the 11 million people in North Carolina. So I'm excited to be in this role. It's an exciting time, as you can imagine. They told me when I took the job, every day is an adventure. And indeed, every day has been an adventure, but it's been incredibly enjoyable. And I get to do a lot of fun things, including episodes like this. So again, I'm excited to be here.
Yeah, definitely.
Well, welcome. Welcome. So I know you probably have real things to talk about that aren't things that we selected based on our heavily curated news, but tell us about what North Carolina is facing with potential non-renewal of these subsidies.
Yeah, that's a great question. So we've expanded Medicaid according to the provisions of the Affordable Care Act a little over a year ago, almost 2 years now. And it was a bipartisan effort here, which is really remarkable. And importantly, everyone knew that what we're trying to do is get access and insurance to those individuals who don't have access and insurance. And so it wasn't the what do we need to do, it was how do we do it? As you know, as you mentioned, the subsidies of Obamacare are pretty generous. When the state puts in a certain amount of money, the feds put in considerable more money. And it's that calculation that allowed North Carolina, again, through a bipartisan effort, to say, let's go ahead and expand Medicaid. So when we expanded Medicaid, one of the provisions was indeed this trigger law that you mentioned. And the idea would be that if the expansion subsidies, which are roughly 90% to 10%, were to go away, then North Carolina would need to start winding back from the expansion population. And it was really designed to manage the fiscal realities of what it would be for the state to then cover that 90% that the feds are otherwise covering. So we're working really hard to ensure that that subsidy remains. One of the impressive things that we've seen here is not only have we had over 650,000 people now have access to Medicaid, we've got good evidence that it can actually start bending the cost curve a little bit. It helps local economies. It helps people get healthier. And it's a win for small hospitals. So there's a lot of collateral benefit that comes, notwithstanding the fact that people actually get the care they need.
Yeah, definitely. We also saw today in the last couple of weeks here that CMS has a new Medicaid director, Drew Snyder. Hasn't been terribly widely publicly announced, but he obviously used to be a Medicaid director in the state of Mississippi, so he has a good amount of understanding of the program. We saw the updates from CMCS that they plan to not approve any coverage that would otherwise have fit into 1115 waivers for things that are not directly related to the provision of healthcare. It's our understanding that that doesn't affect current 1115 waivers. Is that where you all are at with it? Because of course, North Carolina has a active 1115 waiver with some really interesting initial outcomes. So,
oh yeah, most definitely. We certainly hope it doesn't impact existing 1115, but also others who want to go down the 1115 pathway. I mentioned earlier that we've been actually able to show that things like supporting housing, supporting transportation, supporting stress reduction, behavioral health, food can actually avoid more expensive utilization of healthcare resources. So we have an actual published study here, was published in the Journal of the American Medical Association, that showed that for those investments at steady state, you save actually about $85 per beneficiary per month, which makes real sense. Before I took this job, I was a hospital president for 2 years. And I can tell you, the one place you do not want your diabetes managed is in a hospital emergency room. So when someone comes to the emergency room with a diabetic crisis, it's a failure of the system, and it's going to cost 20, 30, 40x of what it would have cost to just manage that in the outpatient setting, including ensuring that people have access to healthy food, healthy resources, and so forth. So that's what our 1115 is able to show.
Yeah, that's awesome. We reported on that on our very legitimate news show. I think we saw it on Twitter or X. I like pretty phenomenal. I think we had previously heard that a lot of these, healthy eating, whatever we're calling it these days. I don't know if we're supposed to still call it food as medicine. I forget. Lisa, what's the current word on the street? We don't know. I think
it's fine.
Everybody knows what we're talking about. We had seen it doesn't actually work. And that I think was one of the first really legit promising outcomes of actually it does, which is super cool.
Yeah, it definitely does. I should have shared that part of that 20-year experience, I worked as a family doctor almost continuously taking care of patients with a bunch of chronic diseases as well as behavioral health issues. And it makes a difference. It completely makes a difference when individuals have access to healthy food, predictable, sustainable access to healthy food. There's a definite win-win there. There's not only the health benefits that naturally result, but this investment in health that individuals have, it actually increases as well. So you get a lot of collateral increases in other things beyond just the health outcomes themselves.
Yeah, I actually was just reading today. I saw that ATA, the American Telemedicine Association, they have a policy arm called ATA Action, and they just launched their virtual food care coalition. So I think the space is still very active. I think absolutely food as medicine is going to be part of the priorities of the Trump administration. It seems like that is part of their sort of priority list around the MAHA movement. And so I do think that there's something there still. So focusing on the ROI and the cost savings for Medicaid from focusing on this should be, I think that will be a important thing that people will pick up on.
Oh yeah, most definitely. And if you think about it, all the inflation of prices and the cost of a dozen eggs debate aside, in the healthcare context, food is still relatively inexpensive as a intervention in healthcare. So if we had to put an economic model on the type of things that we do through an 1115 or through addressing food access, it's a lot cheaper than many of the other things that we would do that sometimes only temporarily buy an improved health outcome.
Yeah, especially at wholesale prices, right? Retail prices of food are one thing, but if you're purchasing at a state level or otherwise, or even as a payer level, that's a very different story. I
haven't thought about that. Maybe North Carolina can go to Costco here and see what we can do. But you're exactly right. Yeah.
Yeah.
Yeah. It's so interesting too. I mean, not interesting, probably more common sense. I was in the UK this past week. I just got back yesterday and hanging out with a bunch of doctors over there. Very obviously interesting approach, different than ours, but everybody was talking about GLP-1s and like all that. The Americans were, and the Brits were like, yeah, I mean, what it really comes down to is like, we just need to eat more and like move more, or eat better food and move more. Like what? And you know, I think it sounds simple, and there's a lot of logistics that go into it, but I think North Carolina is definitely a great example of making stuff happen there. So, what are your priorities for your time serving the state?
Yeah, thanks for asking. As I look at the totality of what this agency does, it really is in three areas. I want to see what we can do to improve access in all of North Carolina communities. We're the second largest rural state in the country, so we've got a lot of rural areas. 100 counties, 80 of them are considered rural. Some are even considered nearly frontier. I didn't even know that term existed until
Wow.
I get closer into into the understanding of what the secretary does. So I want to figure out how we improve access. We know that if you don't have access to all the things that we might do through an 1115, but even basic healthcare like primary care, you're going to go into the emergency room, you're going to go later, you're going to get admitted to the hospital, you're going to stay longer. So I want to figure out what we can do to really improve access in all of those communities. And I think that we've got quite a few levers we can pull at the agency, and hopefully we can move the private sector along the same ways. Second thing I want to do is make sure our programs and services are working for all. We've got a massive agency. This is a mega agency. And while I knew it was big, I didn't fully appreciate how big until I took the job. We do everything from the medical examiner's office to the work that we do for vital records. We do all the licensing of healthcare facilities. We're a certificate of need state. We run that program. We run all the human services programs. And of course, we have Medicaid. So I want to make sure that those programs and services are working for all. One of the phrases that was a big part of the governor's campaign was this idea that your access to or your ability to have health, happiness, wellness, and safety should not be dependent on where you live or how much money you make. And so that's really making sure our services really work for all. And then the third is workforce. And I'm sure if you probably talked about in one of your other shows, or if not, probably will. It's so hard to find labor in the healthcare space these days. So what can we do to create a sustainable workforce? Not just look to fill vacancy rates, but how do we curate individuals' career in a healthcare field, or maybe even in public service? You're talking about public service earlier on this conversation. What do you get people? What do you do to get people invested and involved in that? And that too is a big focus of the state. So I feel like not only do I have some priorities, but they're completely synergistic with what the state wants to do.
Yeah. Can you talk about your rural health approach? This is, I've been like talking a lot about this on LinkedIn about public health, like no one knows what the hell that means. I think oftentimes rural health is thrown on the same way, and people are like, what does it even mean? You're just going to like have more doctors and send them out to wherever, the desert or the mountains or whatever we're talking about. What is your definition of rural health, and how do you intend to increase access to people who live in rural or
Yeah.
frontier parts of North Carolina?
So when we start thinking about rural health, it's really those areas that don't have immediate access to basic health care resources. And primary care is one of them. So I think we've got to do whatever we can to make rural settings a place where primary care providers want to go to start a practice, to build a practice. How do we create incentives in that space? But it's also down the healthcare continuum. If you look at some of our smaller hospitals, they tend to be in those rural settings. They tend to be on very razor thin margins. And so without their ability to survive, then there's no healthcare. Despite the fact that it may not be the best place to get primary care, it is at least a resource in those emergent settings. So we want to make sure we can do everything we can to have those smaller community hospitals survive. Medicaid expansion actually turns out to be one of the best things that happened, because it allowed those hospitals to start collecting for care that was otherwise care that wasn't reimbursed. And so it's really those types of things. How do we create provider access? We've been working also on broadband and telehealth. How can we improve access to those services? It's interesting to me. I think if you had asked a healthcare enterprise 6 years ago, let's do this thing called telehealth, everyone has said, no, we can't do it. It's too hard. No one's going to go for it. And now fast forward 5 years into it, there's good evidence that the outcomes are just the same. The providers like it, the patients like it. It's improved access, particularly in things like psychiatry. So it's how do you really create that provider access in all of these communities? And then finally, trying to be as efficient in this process as possible. making sure that it's easy for providers to be Medicaid providers, so we don't make it so confusing. It's easy for beneficiaries to enroll and to be redetermined. So looking at all of those things that take some of that inefficiency out while creating access in some of those very conventional providers that's severely otherwise lacking.
Well, as you're seeing,
Yeah.
oh, and I'm muting myself. So as we're seeing, so there's all kinds of things that we're like worried about at the federal level. We're seeing people cut, programs change, big questions. I think obviously a big part of the work that you all do, relates to public health at the federal and the local level. And of course, as we know, this whole time, public health has been incredibly, incredibly, incredibly local, right? I live in California, and here in California, a huge amount of the authority for public health activities is delegated down to the county level, right? And it's similar story across many different states. And so just like talk about how you and your colleagues, the governor and everyone are thinking about what do we do right now to make sure that we don't have like massive, scary gaps in public health, whether it's anything from food security to, infectious disease to you name it. Like there's so many ways that public health actions affect our lives, and states are in a really unique place where it was all on you anyway, but at least you had a little bit of support like from the federal. Like, how are you all thinking about that right now?
Yeah, and I think, Lisa, your question is particularly timing, as this week we celebrate public health professionals through more public health awareness. So perfect timing.
Right.
It's my opportunity to say thank you to all the public health workers in North Carolina and throughout the country who are doing the type of work exactly as you mentioned in some of the tiniest pockets of geography, making a difference. So we're continuing to focus on a couple of things. We still have a surveillance system in place that allows us to understand what's happening, particularly when individuals go to the emergency rooms with particular illnesses, particularly respiratory illness. We have a wastewater surveillance system that allows us to understand what's happening, if you will, behind the scenes. So those are two areas that are still there and really important, because public health is really a big part of it, as you know, is about surveillance. The other piece that we're really doing is we're not taking the trust that individuals have in public health in North Carolina lightly. Despite everything going on, this agency enjoys a remarkable amount of trust in the public. People look to us to be the source of truth. People look to us to be honest, to be timely. So one of the things that I've committed to is to do exactly that, to make sure that we communicate as effectively as we can, as truthfully as we can, as easy to understand, and then be prepared to report it, or repeat it rather, because there is some skepticism, and we have to now accept the fact that just because public health said so isn't going to get people to do what we want them to do. Sometimes it might have to be public health reframing the message or repeating the message. But it's all of that that I think allows us to still do the work that's so important in public health, despite some of the challenges and forces that we're experiencing.
So Dick, this has been a recurring us in all of our conversations and then all of our talk shows, right? It's just like, how do you build trust? How do you keep trust? And you just gave some of the things that you all do, but can you talk more about what is North Carolina's secret sauce? Because many states and our great federal government do not enjoy the trust that North Carolina has with its citizens.
Yeah. I look at my experience as a provider to help me think about how we would do this at a state level. There are going to be patients who I remember seeing who couldn't get the medication that they wanted fast enough. And they wanted you to write for that medicine because they'd done their research independently. And oftentimes it was good. So I'm not discounting the work that they've done, but there are those who we can maybe call them early adopters to anything. Then there are those who need that dialogue to understand the pros and the cons, and sometimes may decide on the side of saying, I'm not going to do what the doctor recommends because I'm adding this other level of information. I think it's really important that we respect the fact that individuals may have differing opinions and bring additional information. And one of the ways you break that trust is if you start immediately dismissing, or if you, in fact, start criticizing individuals who can have other sources of information. So I think what it really gets down to, Kat, is engaging in a dialogue on that individual level and this magnifying how you do that for 11 million people. So some of that is in the messaging. And if you have a sense of what you know is going to be maybe the prevailing thought that's not entirely consistent with what public health recommends, how do you get ahead of that? How do you start addressing that at the same time? But I think it's a lot like you need to do with other messaging. When you want individuals to adopt something, you oftentimes have to simply repeat it.
Yeah. I really think that, like, I mean, I can only imagine what your job is like. I can only imagine all of the things you must be hearing and seeing and thinking, and how many different directions you're being pulled in. It's a big deal to do the job you're doing for any state, for North Carolina, for any state. But like, at some level, I would think that when there is controversy about any particular area, gosh, there are just so many other places to go. I feel like you could build your entire public health program around hypertension, or like, there's so many. Like, I'm not saying that we shouldn't care about all those things, because we should, and they're important. But there's also these really like fundamental things that I think we can all still agree on, right? Like, people getting healthy food, like we just talked about, people being able to like move their bodies, go outside if there's a safe place for them to be outside, or to encourage people to be getting more physical movement, to be getting screened for, you know, high blood pressure or for cholesterol, like me just did. Yikes! But you know, like, whatever it is, like there has to still be a core of things that we can agree on, and focusing on those things might be able to build more trust to the things people feel a little bit more queasy about, like, maybe you should wear a mask if in fact you have COVID, maybe you should get a vaccination, or whatever it is. So I just, like, it feels to me like there's always a place to roll back on for the fundamentals of health for populations.
Absolutely. You know, and I should have prefaced my comments by saying that one of the ways you build that trust and one of the ways you communicate effectively is to focus on the science and the evidence. And if there are good data out there, use those data in a way that can be appropriately convincing. And I think most people can get behind good data. They may not buy it instantly, and 100% may not buy 100% of what you're saying 100% of the time. But I think through those other strategies that are coupled with having good data, kind of get to what you were talking about, Lisa, is how do you get almost that coalition of the willing in these sorts of circumstances that allow you to say, you know, we've got an idea here, we got a concept here, we got a thought here, we think we should do this.
Yeah, definitely. And I hope, you know, very much that we can all build on that. But again, like you were both saying, I think the communication about the success stories and why it matters, and being really clear about that, is important. Obviously, we're biased because we know a lot of people from North Carolina, and now we've had two secretaries on our show, a little show here. But I feel like that's
you'll have to tell me which one you like better. You can tell me later. Yeah.
Like,
you know what? I should say, Lisa, I apologize for the interruption. One of the other things that's been a real joy of this job is I look at my two predecessors who held this role, and we actually meet on a regular basis. They've been really helpful in helping me understand some of the do's and do not do's of the role. They've helped me transition. And, you know, you normally expect that when you have government transitions, particularly when it's from the same party in power. But I've been really lucky to have two predecessors who have been engaged and invested in my success. And so I say that I still want to know which one you like the best, but I would be remiss.
we have a few more minutes still, so keep going. Keep going.
Okay, all right. Okay, fair enough.
Yeah. Well, Deb, I do want to ask, one thing I want to say on communications, last thing, because, you know, we could talk about this forever, is I do also think North Carolina does a really nice job of claiming credit for things that they've done.
Yeah.
And being open when things maybe didn't go right, and changing course. I think that is a model. Honestly, it's a model for the CDC in the country. Love it. And I think, again, you do usually lead with data from what I've seen. So I think that's fantastic. I do want to talk a little bit more about rural health, since, you know, like you just said, 80% of the state, you know, rural. There was some, and you talked a lot about, you mentioned broadband. I think I just saw something, and Lisa probably sent it to me, from HHS, saying that they wanted to cut back on Medicaid funding.
That's the thing I mentioned before about the change in the rules for 1115 waivers. One of the examples they gave was broadband for
providers. And I listen, I love efficiency, I'm here for it, but that I was like, why is that a bad thing? You know, why is that being targeted? It's even for me, I'm great at spinning stuff. It's hard for me to understand how that's something that we should not invest in. Do you have thoughts on that?
No, I hope that, you know, part of the entire process we've experienced is There's been a clawing back of some recommendations. There's been reconsideration. There's been other thoughts. The administration, when they maybe haven't gotten it exactly right, have been willing to admit to say, okay, we need to do things differently. I hope that falls into one of the
Mm-hmm.
categories because not only is broadband about telehealth, with everybody using electronic health records, with individuals who now need access to health information across vast distances, broadband is the tool that allows us to do that. I think one of the greatest examples we have now is broadband allows you to take care of a stroke patient in the most rural parts of the state because you have the technology to communicate all the relevant clinical data to these larger, more metropolitan areas where we have stroke experts. Those are the telestroke programs, and you can do in just about
Right.
any, and you can do in just about any clinical condition. You can't do that without broadband. So I hope that there's okay, we're going to turn that one back on, or maybe not have broadband as impacted as maybe some of the other areas that are in focus.
Yeah, maybe a misunderstanding, and who knows? Things are moving
Yeah.
really fast. I agree. I hope that is either a mistake or a misinterpretation or whatever it might be. Because yeah, even the other thing that I thought was interesting about that is this administration seems very focused on it is really hard to fling around high quality data if you are on dial up.
Yeah.
Yeah,
Pretty
and
hard.
I have a kind of a follow-up question on the on rural healthcare and providers, especially from your background of as a physician and working in the space for a long time. There have been lots of questions about how do we get appropriate care into rural areas, right? There's like some combination of like telehealth of various types, some longstanding problem of like of providers, of physicians, not wanting to stay necessarily in rural areas or getting the right people trained and positioned there. Like what are your thoughts about what we do about sort of the lack of physicians and providers in rural areas? Like what are you all looking at? What are you thinking about there?
Yeah, that's a great question, and I think some of this may have been addressed either directly or indirectly in those 9 strategies that Mark Cuban has
Mhm.
outlined.
Yeah. Yep.
We know that specialty choice and
Medical
medical
school,
students,
cost of
yeah,
medical school.
medical school. I mean, the average medical school now is somewhere, private medical school is north of $100,000 a year. So if you go into, it's unreal. So if you go into
Oh,
that space with $400,000 with the debt that you need to pay back, not to mention undergraduate debt, how do you find your way to choose a specialty that is going to give you a lifetime earning that may be $6 to $10 million less from a specialty earning? So that's just one piece, and kudos to all the medical schools with the AAMC is trying to do to reduce the cost of medical education, but that's just one piece. So what can we do to lower the cost of actually attending medical school, which will directly have an impact on specialty choice? I also think that there are ways to get more creative. Now, this is Dev talking, not with the secretary hat on, to get more creative around, does medical school really need to be 4 years? Maybe we can make it 3 years. Again, that makes individuals get out of the pipeline faster. It lowers the economic burden of going to medical school. And that's just one part of how do you create that access. And identifying those individuals early. We know individuals who grow up in rural communities are more likely to come back and to contribute to rural communities. So what can we do to really identify those individuals early, whether it's in high school, early in the undergraduate program, and give them an opportunity to think about what it might mean to serve the rural parts of the state? And then finally, as much as we may be rural, it's not hard to travel. We know that rural is your day to day, but one of the beauties of North Carolina is you're never too far from a major metropolitan area. And depending on where you aren't too far from the beach or the mountains. So all of that stuff together really gives you an opportunity to think about how do you sell rural and how do you sell it early?
yeah, definitely. Um, I also just picking up on that, that's a whole rabbit hole we could go into about medical education, but I also just have such a hard time understanding why other countries with really high quality medical education can combine an undergraduate and a medical degree, but we somehow can't do that. It's the weirdest like lack of innovation in training education I could imagine. Like why, if you're somebody who knows you want to go into medicine, why can't you start doing that from your first year of like post high school education? It's the weirdest thing.
It is.
And I don't get it. There's so many ways we could innovate in getting more high quality medical doctors trained in the US. And we
Fantastic.
just, we
Yep.
don't. But we
Well,
should.
and if you ever want to have a show without Dev, the secretary, and Dev, the medical
Yes.
educator, on, I'm happy to share my thoughts on all of these things, because you're exactly right. There is an efficiency argument that we can make that can really help individuals find their ways to practicing high quality healthcare wherever it is, whether it's a rural community, whether it's more metropolitan, and take some of the inefficiency out of the system.
That's awesome.
Well, you can come back anytime you want. I mean, you handled our bullshit. You kind of raised the bar
End of the
of
job,
legitimacy.
that's a big
Anytime.
deal. Big deal.
Well, this has been an absolute pleasure. I enjoyed the first 30 minutes of the program and listening to it. And I think it's great to be able to have just a free spirited conversation around some of these topics that could otherwise be mind blowing.
Awesome.
Yeah, well, some people call us mind blowing. I don't know.
Fair enough.
Gauntlet drop though. Gauntlet drop from North Carolina to the other states. Like other states, please take note. Like North Carolina is already beating you on the comms around all of this and the willingness to share and learn. So like
Fantastic.
Other states, come on the show.
Come on over. I don't know if you can take the heat, but okay, Deb, we are out of time, but with our last few seconds here, tell our million loyal fans what anything. Actually, tell them anything you want. What do you want to tell them?
I think that despite all of the challenges that we have in healthcare and what we're wanting to do to improve the health of communities, it really is an exciting time. We've never had the type of tools we have. We've never had the type of engagement that we have. And I go back to what one of the earliest things that you mentioned. We got to get people asking questions. Because until you ask questions and until you continue to engage in dialogue, we're not going to fix the system. So it's conversations like this that allow us to do that.
Yeah. Awesome. I bet you knew who the Palantir guy was. That's great. I did not, but yeah.
Just me and Deb.
We love that guy.
And I knew.
Whatever. All right. Well, Deb, thank you for coming on our show. Thank you for your comms team for allowing this to happen.
This is great. I loved it.
Incredible. Thanks, Deb. Thanks, everyone.
All righty.
All right. Happy weekend, y'all.
See you later. Bye.